So these are then slides from the ASCO presentation to set the stage for you for RASolute 302, which was the trial that was presented. So you can see on the left, there were key eligibility criteria: adults with metastatic pancreatic cancer. They must have had one prior line of chemotherapy, and they must have had documented RAS mutational status. However, all patients could enroll regardless of the mutant allele or if they had a wild-type RAS status, but we did have to know for them to enroll. There was 1-to-1 randomization, daraxonrasib, which is given at 300 milligrams orally once daily, or investigator choice of chemotherapy. In the second-line setting for metastatic pancreatic cancer, we use a variety of different chemotherapies depending upon what they received in the first-line setting. So this trial was designed to provide maximum flexibility for the patient and their oncologist to choose what was appropriate for them in the second-line setting. And then there were dual primary endpoints of overall survival and progression-free survival, and a number of secondary endpoints. And this was a global trial that was open at 59 sites across 6 countries in North America, Asia, and in Europe. So just to give you a sense of the patient distribution or disposition, there were 500 patients randomized over about a year, about half and half, again, to daraxonrasib and to chemotherapy. You can see that the chemotherapies received in the control arm were the standard types of chemotherapy we generally use in our practice, including gemcitabine and nab-paclitaxel and 5-FU-based chemotherapy. You can see as we got to the time of the reporting of the data, 42% of patients on the daraxonrasib arm were still on treatment with daraxonrasib, compared to about 14% of patients who were receiving treatment on the chemotherapy arm. If we then look at overall survival, this is in the overall population. So again, all comers to the trial, regardless of mutant allele or wild type versus mutant status. You can see that there was a substantial benefit in overall survival for receiving daraxonrasib compared to receiving chemotherapy. And you can see at the medians, this was 13.2 months for the arm who received daraxonrasib and 6.7 months in the arm who received chemotherapy, with a hazard ratio of 0.4 and a significant p-value. If we then go into a number of the other endpoints, including progression-free survival, this is by blinded independent central review. This slide has both the RAS G12 population, which was one of the endpoints of the study, and also the overall population. And you can see, again, a substantial improvement in progression-free survival for patients who received daraxonrasib versus received chemotherapy. Again, hazard ratios in the 0.4 to 0.5 range and highly significant p-values. If we then look at response rates, this is the confirmed objective response rate, again, by blinded independent central review. Slide is set up very similarly with the G12 population on the left and the overall population on the right. And you can see, again, a substantial improvement for patients who received daraxonrasib versus chemotherapy. The objective response rate was between 30 to 33%, depending on the 2 cohorts that are described here, versus around 11% if patients received chemotherapy. So an improvement in objective response rate. If we then talk about safety, and Dr. Velaswamy raised the safety findings with daraxonrasib in his talk also. There's a lot of numbers on this slide, but I'll just highlight a few. First, you can see patients were on daraxonrasib for substantially longer than chemotherapy. That's, again, because patients had substantially longer progression-free survival. But if you look at the toxicities that led to dose reduction, that was about a third of patients with daraxonrasib needed a dose reduction, and almost 60% of patients with chemotherapy. And mostly that dose reduction for the daraxonrasib group was due to rash or inflammation in the mouth, stomatitis. The dose reductions for chemotherapy were the ones we're usually aware of, right? We've been using these chemotherapy drugs for many years now. If we also look then at dose discontinuation, so meaning stopping study treatment because of treatment-related adverse events, this happened in about 1% of patients who received daraxonrasib and about 11% of patients who received chemotherapy. So although there are side effects that we see, that did not lead to many patients to come off of trial or off of daraxonrasib because of side effects. And then if we take a little more granular look at the side effects, to the left is daraxonrasib, to the right is chemotherapy. Really, there's four main things we see with daraxonrasib. Rash we mentioned, but you can also see diarrhea, stomatitis, and nausea. You can see most of that is grade 1, 2, and a slightly larger percentage of patients, when we look at this, have rash and stomatitis as a grade 3 toxicity. For chemotherapy, again, looking down the list, it's all the things we tend to see with chemotherapy: blood count suppression, neuropathy, nausea, diarrhea, the usual things that we see. I think, as Dr. Villaswamy mentioned, we've really started to learn a lot more about how to manage the rash with daraxonrasib, and I think there'll be increasingly data out there in the literature and guidance on how to do this as we learn how to manage this. And I think we're getting quite a bit better at it, and I hope we'll see lower rates, particularly of more severe rash, as we start to implement these procedures. And then finally, to complete sort of the data package around this, there also was improvements in quality of life for patients who received daraxonrasib versus chemotherapy. These were two different measures of patient-reported outcomes, one for pain and one for global health status, and there were substantial delays and deterioration of these in patients who received daraxonrasib compared to chemotherapy. So if we do take a step back and look at the conclusions then from this trial, the RASolute 302 study, daraxonrasib as an oral pill given once daily demonstrated statistically significant and substantial improvements in overall survival, progression-free survival, and objective response rate compared to standard chemotherapy. These benefits were demonstrated consistently across all the patients who are in the trial, and there'll be more data over time as we think about specific mutant alleles. There was a manageable safety profile. Nothing new was really identified that we didn't know from the prior phase 1 or 2 trial, and very few patients came off of daraxonrasib because of toxicity. And then lastly, there was substantial and significant delay in time to deterioration of symptoms such as pain and global quality of life for patients who received daraxonrasib versus chemotherapy.